Hello, I am Dr. Parvez, and today we are going to deal with pediatric emergencies. And uh, let us discuss abdominal pain. 3 month to 1 year old baby. Intussusception is the main emergency. Distal ileum. This is the distal ileum. It telescopes into the distal bowel. This is the distal bowel, and this is the distal ileum. You see, this is ileum. It has entered into the cecum. Here it has telescoped into the distal bowel and has caused intussusception, uh, intussusception. Okay, and this is the colon. So intestinal obstruction is resulted and sudden screaming attack of pain with vomiting, and child looks pale, lethargic, anxious, and unwell. Bleeding is a late sign. So intussusception associations are recent viral gastroenteritis, infantile spasm, Henoch-Schönlein purpura, arthalgia, skin rash, and nephritis. Is the triad of Henoch-Schönlein purpura. Diagnosis: sausage-shaped mass in right upper chondrium, and plain X-ray, normal or bowel obstruction, and ultrasound. Diagnosis: gas or barium enema. It will demonstrate the position of the apex of intussusception. See here, we have taken the X-ray gas or barium enema, and here we have, this is the intussusception. We have seen hydrostatic reduction under USG. Hydrostatic reduction under ultrasound, surgery if enema failed, peritonitis or septicemia. Fail of anemia, and if enema failed, peritonitis, or if there is septicemia, we'll go for surgery. Ileocolic intussusception. This is from Anthology of Book of Pictures. We give full credit to that book, and please go through that book, please read that book, and at least know all the pictures. Here you can see this arrow pointing towards intussusception. This is the margin of intussusception. Abdominal pain, older children. So main abdominal pain cause is appendicitis, any age, rare under 5 years, anorexia, vomiting, and localized abdominal pain, epigastrium, periumbilical region, right iliac fossa, tenderness and GORDing in right iliac fossa, rectal examination. Appendicitis, how do we diagnose? Physical examination, abdominal auscultation, palpation, and percussion. Full blood count, urine analysis, leukocytosis, rule out UTI. Pregnancy test, female adolescent. USG, female adolescent. Doubt and no peritonitis. Remember, adolescent is age between 10 and 19 years. 10-year-old, 19-year-old, they are adolescent. USG, female adolescent, doubt and no peritonitis. CT, neurologically impaired, immunologically suppressed, or obese, doubt and no peritonitis. Typical march of symptoms: J.B. Murphy, prodromal mild bowel upset, development of abdominal pain which progressively worsens, and there is anorexia, nausea, and vomiting. Moderate fever, signs of fecal peritonitis over the inflamed appendix. You remember, this is the diagram. Here you see two right and left hepatic ducts meet, form the common hepatic duct that fuses with cystic duct, forms common bile duct. That common bile duct posteriorly in relation to duodenum comes meets main pancreatic duct. This is the ampulla of water The carcinoma of ampulla of Vater is a very common MCQ, and this is the duodenal papilla, open in duodenal papilla. Come to vomiting. Vomiting may be, so the appendicitis is over. Now let us discuss vomiting. Vomiting may be green in neonate. Vomiting in neonate, it may be green, bile stained, and it is due to duodenal atresia, small bowel obstruction, sepsis, infection, UTI, and otitis media. What are the 4 causes of vomiting? Try to remember by heart. When it is green, bile stained, duodenal atresia, small bowel obstruction, sepsis, infection, UTI, otitis media. When it is milk stained, it is pyloric stenosis, it is GORD, it is infection, and UTI, otitis media. See, infection, UTI, and otitis media, it may be both. A causative factor, it may cause milk stained, it may cause bile stained, no worries. And so, but you have to remember pyloric stenosis, GORD, milk stained. Duodenal atresia, small bowel, sepsis, green, bile stained. Then we have pyloric stenosis. Pyloric stenosis, metabolic complications are vomiting, loss of water, HCl, and we have vomiting in kidneys can initially conserve H+. Once dehydration, water and sodium are conserved in exchange for hydrogen and potassium. Then resulting condition, hypovolemia with alkalosis, low chloride and potassium. So hypochloremic, hypokalemic, alkalosis will be caused. Diagnosis and management. If diagnosis suspected, first do test feed. Feel tumor, wave right abdomen or immediately after vomiting. Ultrasound, admission, blood test, electrolytes and acid-base disturbances. Pyloric stenosis, if shock, 20 ml per kg of normal saline, IV fluid replacement, 0.45% half normal saline with 5% dextrose. Potassium, once the baby is passing urine, 20 millimole per liter KCl if mild or 30 millimole per liter KCl if moderate or severe. Surgery, refer to pediatric surgeon for pyloromyotomy. Explain that is excellent prognosis. Gastroesophageal reflux and gastroesophageal reflux disease. What is gastroesophageal reflux and what is gastroesophageal reflux disease? Gastroesophageal reflux is passage of gastric content into esophagus with or without regurgitation and vomiting, lasting less than 3 minutes in the postprandial period, with few or no symptoms. It is result of an abnormally functioning lower esophageal sphincter, which in infants it is usually due to developmental immaturity of the sphincter. You remember GOR, developmental immaturity of sphincter. Peak at 4 months of age and usually resolves by 12 months of age. Begin and usually does not affect child health. Peak at 4 months, resolve 12 months, developmental immaturity of sphincter. This is GOR. Consider when GOR causes troublesome symptoms or complications. FTT, hematemesis, refusal to eat, sleeping problems, chronic respiratory disorders, stricture, esophagitis. This is GORD. Consider when GORD causes troublesome symptoms or complications, it is called a GORD. When it causes hematemesis, refusal to eat, sleeping problems, other things, okay. GORD, irritability and crying, sole manifestation. Vomitus just ingested milk. Vomitus may be projectile but not persistent. The majority of babies continue to thrive, gain weight. Complications: peptic esophagitis, peptic stricture, failure to thrive, uncommon. Pulmonary complications: persistent cough, wheeze that may result from aspiration. How to diagnose: healthy infant whose main symptoms are vomiting and regurgitation. Reassurance: avoid excess handling. Posture after feed: head up position at or near 30 degrees. Small and frequent meals. If symptoms persist, barium esophagogram to exclude anatomical abnormality such as stricture, gastric outlet obstruction, and malrotation. Acid reflux related symptoms suggestive of esophagitis. Endoscopy and biopsy is most appropriate. So GORD, if symptoms persist, barium esophagogram. Acid reflux related suggestive of esophagitis. Endoscopy and biopsy is most appropriate. Atypical symptoms: aspiration needs to be considered. Barium esophagogram, chest X-ray. Chest X-ray, remember, ambulatory 24-hour pH monitoring may detect the presence of GORD but does not prove the association. Are you remembering? Are you concentrating? GORD. What we do, we reassure. Reassurance. Medications: Mylanta, H2 receptor agonist, proton pump inhibitor. GORD treatment: Mylanta, antacid, H2 receptor antagonist, proton pump inhibitor. Surgery: complications of medical treatment